Let's get right into the next best step logic for breast and pelvic floor presentations on Step 2 CK. When you're working through these questions, your moves are strictly dictated by clinical variables. We're talking patient age, symptom cyclicity, and things like vaginal pH. Starting with a palpable breast mass, age is your ultimate guide for imaging. For a patient under 30, you generally start with an ultrasound. But if they're 30 or older, you're reaching for a mammogram, frequently combined with an ultrasound. Now, keep in mind that if your physical exam is highly concerning for malignancy, imaging alone won't cut it. A core needle biopsy is absolutely required for suspicious solid masses, regardless of how reassuring the imaging findings might look. For symptomatic simple cysts, you're going to manage those with needle aspiration. If you get clear fluid and the cyst completely resolves, great, just schedule a repeat exam. But if that aspirate is bloody, or if the lesion is persistent, recurrent, or complex, you need to grab additional imaging and do a biopsy. When dealing with benign breast disease, differentiate things by cyclicity and focality. Fibrocystic change gives you this diffuse, bilateral cyclic tenderness without a focal mass, which you treat conservatively with a supportive bra, NSAIDs, and reassessment after menses. On the flip side, a fibroadenoma is a mobile, well-circumscribed firm mass, usually in younger patients. You observe adolescence when it's classic, but you definitely image persistent masses. Watch out for fat necrosis. Following a history of breast trauma or surgery, this can really mimic breast cancer. It presents as a firm, irregular mass, and you'll often see calcifications on the imaging. Moving to nipple discharge, you have to separate physiologic from pathologic. Physiologic discharge is typically bilateral, multiductal, and only expressed with manipulation. Pathologic discharge, however, is spontaneous, unilateral, bloody, or associated with a mass. When it's abnormal like that, you jump straight into age-based imaging and biopsy. A classic exam scenario is the intraductal papilloma. This is a benign tumor that presents with unilateral, spontaneous, bloody nipple discharge, but crucially, without an associated palpable breast mass. For galactorrhea, the workup follows a very specific sequence. Always start with a pregnancy test. Next, measure prolactin and TSH levels and do a thorough medication review. You only move on to a pituitary evaluation if those initial steps point you there. Lactation problems follow a rigid, predictable timeline. Immediate postpartum nipple injury, like pain, abrasions, or cracking, stems from a poor infant latch, which you manage by observing the feeding and correcting the latch. A few days later, bilateral symmetric engorgement occurs when the milk comes in, improving with frequent feeding. Further down the line, inadequate emptying causes plugged ducts with focal tenderness but no fever. You also need to cleanly distinguish between afebrile issues. Take the focal firmness of a plugged duct and contrast it with a galactosyl. A galactosyl is going to be a mobile, well-circumscribed subareolar milk retention mass. Again, neither of these give the patient a fever. Add a fever into the mix and things change. Mastitis presents with fever, myalgias, and a red, tender, swollen breast quadrant. The move here is to continue breastfeeding or pumping and give analgesia and antibiotics. But if you feel a fluctuant mass, you're dealing with an abscess. That requires an ultrasound plus immediate drainage. Now, what if you have afebrile, unilateral breast erythema and swelling that simply doesn't respond to antibiotics? That presentation, especially accompanied by a peau d'orange appearance, points directly to inflammatory breast cancer. Shifting gears to menopause. For recently menopausal patients dealing with bothersome vasomotor symptoms like hot flashes and sleep disturbance, systemic hormone therapy is used. Just ensure they don't have any estrogen contraindications, like coronary heart disease or a history of breast cancer. Then there's the genitourinary syndrome of menopause, or GSM. This causes vulvovaginal dryness, burning, dyspareunia, recurrent UTIs, and urinary symptoms. On exam, you'll see a pale, thin mucosa, decreased rugae, and a vaginal pH above 5. You manage this with moisturizers, lubricants, and topical vaginal estrogen when appropriate. With pelvic organ prolapse, whether it's a cystocele, rectocele, enterocele, or uterine prolapse, patients usually report pelvic pressure, a bulge, or obstructed voiding. Your management sequence starts with weight loss and pelvic floor exercises, then moves to a pessary, and finally surgical repair. Speaking of surgery, colpoclesis is a definitive surgical closure you need to know. It's indicated specifically for older patients with severe pelvic organ prolapse who no longer desire vaginal intercourse. Let's break down the three main types of urinary incontinence. Stress incontinence is leakage with a cough or laugh. treated with pelvic floor therapy, a pessary, or a mid-urethral sling. Urge incontinence is that sudden urgency and frequency, managed with bladder training and antimuscarinics or beta-3 agonists. And overflow involves constant dribbling and retention from incomplete emptying. A highly testable point. In older patients presenting with acute urinary incontinence or delirium, the immediate next best step is checking a urinalysis and culture. You have to rule out an infection first. For premenopausal sexual pain with an unremarkable external pelvic examination, you're looking at genitopelvic pain/penetration disorder, sometimes called vaginismus. The key management here is desensitization therapy to help relax the vaginal muscle spasms. To wrap up, differentiate pelvic fistulas by history and fluid type. Vesicovaginal fistulas cause continuous, painless urine leakage following pelvic surgery, radiation, or prolonged labor, and are diagnosed with a dye test or cystoscopy. Rectovaginal fistulas present with flatus or feces passing from the vagina, typically following severe obstetric trauma, Crohn's disease, or surgery.